Good evening, all the aspirants. Today is a special session, and the speaker for today we have here is Dr. Ranajit Chatterjee. He is a HOD in critical care at Swami Dayanand Hospital, Delhi. Sir, you can start the session.
Well, good evening again, my dear friends. I think we have met before also on webinar, not maybe directly live, because everything nowadays on webinar, your exam is also not live, unlike our times when we had to give the exam. We went to, for my EDIC part 1, I went to Malaysia, and from EDIC part 2, I went to England, where we got a live patient, and the exam pattern was completely different than what you are giving now. So now there, the exams till 2013 was by the patient sides, and from 2013 a different type of format came, and nowadays it is more robotical type of exam. Beforehand, when you are giving the exam, it has a lot of questions can be asked by the examiners according to their own will, which is now being restricted. You have a set pattern of questions, you have a set pattern of pictures which you have to answer. Remember, all of you might be doing intensive care for the last couple of years, and you are all consultants. You don't have to prove yourself by passing this exam, you are already consultants. And I'm sure that as you don't have to prove it, you will automatically pass it. Because those who are working in the intensive care, they will pass this exam. Because it is the first part of the EDIC is basically to test your theoretical knowledge. The second part of the EDIC is basically to test your practical knowledge. So they will see how practically you are oriented as a consultant. And so I am sure that most of you will pass this exam. So I will share my slides. As you know that the exam has been divided in approximately 2 hours. And you have a clinical case scenarios. You have also that is the pictures and different type of graphs. The 3 parts will be coming there, the CBS part and the CCS part. So computer-based scenarios will be coming and the clinical case scenarios will be coming. And you have to answer them in the stipulated time as quickly as possible. And read the question very well. Have you attended my last class where I have already shown you about certain cases, certain atypical case? Did you see? Have anybody attended? You can just unmute yourself and talk if you can. So that because monologue is always very boring, you know. It would have been a dialogue, it is always better. Just see the type of scenarios that you'll be getting. We have already discussed many. Now you must be reading also, but be free in your mind. Only 3 days left for your exam. Do not take any stress here. I have seen very familiar names which are here. We have interacted before. And there's a question on reverse triggering that was coming, that why it is different. We'll discuss this today. All right, because this type of things will be asked. And I'm sure that you must have read about double triggering, reverse triggering, pseudo reverse triggering. How many of you know about that? So you can Google it again. You will get. So there is not a problem. Now Google is always there for your help. So suppose you get, this is a very common question that you get, and we have already shown it, I think, before, but I thought to change certain pictures and show you again the newer ones. So what is the lesion? What is the reason of this lesion? What do you think that what is this one? So when you get this type of picture and that to the ponds, you just can't think anything else but any infarction in the ponds. Somebody will
Acute
think an infarction in the ponds,
short
but
water
uh,
made analysis.
exactly. So nobody is going to give you any infarction in the ponds suddenly in an intensive care. So obviously it will be related to something which is basically related to our own subject. So that you have to keep it in your mind. And central pontine myelinosis, they can directly give this type of picture also in the occipital lobes. And they can ask that completely changes the picture actually. So if they keep the same picture and you get two bilateral occipital lobes, this type of opacities, white opacities in the MRI, what do you think what it will be
West
in a
syndrome.
Yes.
pregnant patient?
Press
Yes.
syndrome.
Press.
Yes, right.
Press,
So
press.
again, when you say the full terminology, all right. If you say press, it's fine, but uh, it is better that you always do not give the abbreviation, but better you say the whole terminology. So that will be better. Yes, that you are all prepared. I'm sure. So you might have seen this one. This is I am very fond of this one. What is this one?
High flow oxygen. Helmet and IV.
All right. This is a helmet and IV. Do you use it?
Pediatric patients.
Pediatric patient. This is an adult patient here. So in my ICU, whatever I'm showing, I am showing from my ICU. See the settings that we are giving here in the helmet and IV. We are giving a setting of around, we're giving a high flow here, around 55 liters per minute. We are giving what is the end of a face mask is the beginning of an helmet. So I'm giving a PEEP, which is the end with the that is the expiratory positive airway pressure EPAP of 10. And the IPAP here is 10 plus 15, that is pressure support is 25. I'm giving a 50% oxygen. Helmet should always be used with the help of a ventilator, not with the help of a BiPAP machine. The main things that you should remember during a helmet, if by chance they give it, because these are the new things that will be coming up, and they might be giving you either a video or maybe a picture, and what settings they're asking you. So remember that in order to get the best of the settings, I start with a PEEP of 10 and a pressure support of 15, and we give we try to decrease the circuit length to around 65 centimeters because these are all studies. These are all studies related to helmet. So 65 centimeters because it has a very big dead space. So you have a chance of asynchrony, lot of asynchrony is there. So you have to give a lot of flow inside, as much as flow is possible, and to keep the rise time as less as possible. And there is a cushion, if you can see properly, there is a cushion also. I think there is an external cushion, you can see this, the translucent one here, but there is an internal one also inside. So you have to fill up, you have to basically inflate that cushion also. This circle is basically this one, the circular thing. You can open this up, give the patient some amount of water, and the patient can talk. These are the patient can speak, the patient can read, the patient can eat. These are the advantages of the helmet. The main problem is that the CO2 washout is not very good, and obviously you have to use a lot of flow here and use a helmet, use a ventilator, that to a turbine-based ventilator, which generates a lot of flow rather than a compressor-based ventilator. These are some small tips about helmet. If I get a chance anytime, I can discuss it in details. So
IEU issue is the same.
yes, yes.
IEU issue is the same.
How I use
IEU issue.
IE
I
ratio. All right, IE ratio. Yes, IE ratio. See, IE ratio you keep it is around 1:2. All right. And normally when this patient is breathing spontaneously, when the patient is see when I select an IE ratio in a BiPAP machine, I select a spontaneous time mode. The IE
Yes.
ratio is basically meant for the time part if the patient is suddenly stopping its ventilation. Then the patient then it will be a backup mode that has been given. Here in a pressure support mode, if you go to the advanced settings, you will find if the patient stops breathing, then there is a apnea ventilation is on. There only the IE ratio comes into action. So normally when I am ventilating from a ventilator, that it becomes different from that what we are ventilating from a BiPAP machine. Yes, I keep the IU ratio. But if I want a, if a COPD patient comes, I keep the IU ratio 1:3 or 1:4. If an ARDS patient, early ARDS, I'll keep the IU ratio at 1:1, 1:1.5. It varies accordingly of the patient conditions. So this is one. So you know what is this one? This is a very easy one. I showed a different color last time. I'm showing you a different color this time.
This is
So
methylene
why
blue.
yes? Is the
This
color
is
of the urine. What is the cause?
green urine, sir.
Green.
Yes.
Yes,
Phenol.
what is the
Propofol
when
infusion.
when they give
Propofol infusion leading to
right. Fantastic. It is a propofol infusion. You all know about it. This is a phenolic derivative of the propofol. Propofol gets metabolized by oxidation, reduction, and glucuronidation by the cytochrome 450 in the liver, and from there some of the phenolic derivatives come out. That basically sometimes cause this problem. It is completely harmless situation, but they might be giving you. Last time I showed you urinary color, so I'll show you that also, because who knows, they might be given this one. If you see this one, what is this one known as?
cola colored urine.
Yes, this is for
hydroxycobalamin, I think, was given.
this is
No.
for
This, I think, patient was given hydroxycobalamin.
Hydroxycobalamin.
right, because hydroxycobalamin is used in a cyanide poisoning, so that is
Toxicity.
cyanide toxicity, and from there it is an antidote itself, because one about this color. All right, so what is this?
Just one query.
Sinusoid sign.
Blood sign.
What sign?
And the
Blood
last,
sign and sinusoid sign.
so
First
this
of all.
basically is
Sinusoid
showing a
sign.
very small pleural effusions, isn't it? You have to remember that the left one is the quiet shine, basically is a static parameter, whereas this is the M mode, there's a dynamic parameter of what is shown in the with the help of the ultrasound. Fine, fantastic. What is the diagnosis of this one?
SVC
This
syndrome.
could be Harlequin
This is the
syndrome.
mediastinal
Harlequin
syndrome.
syndrome.
SVC obstruction syndrome.
Yes, easy
Could
time. So these are easier questions than the last time I gave. So these are easier questions, and you will give easier ones. So don't worry. If you have not attended the last class, can you tell what is this one?
Abdominal pressure monitor.
Yes, but they will not give this advice, this hint of monitoring device following exploratory laparoscopy. They will not give you. So they'll directly give you an abdominal pressure monitoring device. And most of you have not seen this one. Again, I'll show you, because I feel very deeply that they will give you this question.
Anaconda. This is Anaconda.
Idaconda.
Anaconda.
That is already written, isn't it?
Yes.
So, and you saw, I think, the last time, many of you, and those who have not seen, this is Anaconda device, anesthesia conserving devices, which are we use basically isoflurane and sevoflurane to this one. It goes to the patient around 2 ml per hour, we push it, and it goes to the patient again. The patient breathes out, which is being absorbed by one of the absorbers here in this black color device, which again push it back. It is just like a HME that is being used, advanced type of HME. That's what is being used here. So, so they will give you definitely some videos. I have shown this video before also, and you can tell me what is this video. This is very easy. I showed you last time.
There is absence of pleural movement.
There is absence of pleural movement, that is lung sliding, abscess lung sliding.
That's right.
Absent lung pulse. See, the pulse is also not there. Otherwise, you would have a pulsatile sensation here.
Barcode.
Absent lung pulse.
Barcode.
In the aim board, I find barcode sign.
Barcode side.
And
Pneumothorax.
yeah. And here is what is this point known as? Here is a seizure
Lung
sign,
point.
lung
Lung
point. So
point.
everything has been shown here. They will definitely give this type of questions to you. So be ready for because ultrasound is being used in such a way nowadays. Every intensivist is becoming an ultrasonologist. So they feel that we are an ultrasonologist. We are not. We have to only use this according to our own situations. For example, this one. A ventilated patient following a lower abdominal. Again, they will not give you this type of hints, but still I'm giving. abdominal surgery suddenly desaturates and become hemodynamically compromised. I have given this question just to make you understand, again to make you again remember how it presents. The P peak and the P plateau in the ventilator is normal. The D dimer is increased. What is the phenomenon in the echo called? How do you diagnose the condition by the bedside?
McConnell sign.
So even without seeing, you are saying that is a McConnell sign. So see that how well prepared you are. So you get McConnell sign. I don't know why they are very fond of this question. So they'll give this type of questions. So now if I can show you some graphs, some loops and graphs, for example, this one. What is identify the situation?
Double trigger.
Can I ask you
Oh,
one question before?
yes, please.
Regarding this greenish urine, I mean, should we mention that it might happen with methylene blue infusion as well? Because there should be some differential diagnosis, isn't it? Or
They basically will ask you if they. I believe that they'll ask. Don't ask you for the differential diagnosis. Okay, and some
right.
phone is.
Okay.
I don't believe that they will give you some differential diagnosis, but still, I think that directly for the for your for the. I better to say that this normally used seen when the propofol is being used for prolonged time. So, for example, not directly it comes. I have not seen. Have anybody of you seen?
Yes.
You have seen?
Yes.
And what do you find?
I
It is
when
for propofol? Propofol for prolonged infusion?
no, with methylene blue.
Your methylene blue, it comes with methylene blue also, but that is not exactly this type of light green that comes actually. Certain dyes like methylene blue, definitely it causes. In certain UTI infections like Pseudomonas also, yes, we might get green urine. But propofol infusion, I think, is the right answer to be given. But yes, if they ask you a differential diagnosis, even sometimes bile when gets secreted, I don't know whether it might be. But Pseudomonas, yes, I remember that might be there. So, yes, you are right, my dear. So, you might get this type of
Sir,
confusion
can
might
paraquat
arise.
poisoning also?
I'm not sure. I'm not sure about paraquat poisoning. I don't think so. I'm not sure. I have to
Paraquat
check.
causes greenish discoloration of upper respiratory tract. I mean, lips, tongue.
But urine, I'm not sure.
Yes, urine, I'm not sure as
So,
well.
I'm not sure. I've not seen actually. What I have not seen, why should I tell you? But I was just telling you the reason of giving this question is that they might ask you this type of certain visual questions. They sometimes give you such very questions which doesn't make any sense actually. This type of questions also comes. So this is double triggering, you're right. So, and how do you reverse this situation?
Increase the inspiratory
By
time.
prolonging the inspiratory time.
Increase the
Yes,
sedation
you are
as
right.
well.
By
And
prolonging the
increasing sedation.
Yes. By prolonging the inspiratory time, that is the answer actually. So if I show it this one, so the question comes here, basically, the inspiratory time is less. First of all, the patient triggers the ventilator and the breaths come. But patient wants to be there in that mode. So, but the inspiratory time is less, so it triggers the ventilator, give me something more. So that is double triggering. But when a patient is deeply sedated, the ventilator basically triggers the patient that you take a breath. So basically this is a completely different thing. So that is reverse triggering. So I don't know that how much reverse triggering, because again I told you that reverse triggering has not been seen by many of us, because those who are not doing the night duties because it is seen mainly during the night time when the patient is deeply sedated. So that what is the second one is the patient's own breath, and obviously the tidal volume is increased. There is a chance of self-inflicted lung injury with this type of situations. That might be one of the reasons of why we tell that the reverse triggering might not be so good for the patient. Not very well seen, may not be, they might not be giving you, but in 2012 onwards, this has been coming off and on in patients. So this is reverse one. So I showed you this one. About capnographs, they can give you anything. So read the capnographs well. They can give you anything there. So this is an endobronchial intubation that you can know. What is
Right,
this
yeah.
one? What is this one?
Bronchospasm, the phase 3 slope is increased.
I think Priyanka, you are speaking, no?
Yes.
Yes, it is basically a bronchospasm. You can say basically this is a pigtail capnograph, known as pigtail capnograph. Seen in pregnant patients, in obese patients, the last part where the spasm is taking part, because they may ask you that I did the phenomenon in capnograph. So the pigtail capnograph. All right. So pigtailing. Yes, this is the last part of the spasm that comes, is that causes this one. So this is pigtail one. So these are very easy ones that you can very well, this they will not give. This they will not give. I've just kept it.
How to be
What is this?
Ineffective
Ineffective
trigger.
triggering.
Huh?
Yeah, sir.
Ineffective trigger.
Ineffective triggering.
Ineffective breath, right? Is ineffective wasted breath. So what basically what is the problem? Why it is happening?
The triggering is very high. You need to decrease the triggering, for
Yeah,
example.
they have to keep the triggering so high. So these type of questions they'll not give. This is a very easy question.